First of all, I discuss some basic aspects and then go on to at what stage and how we manage various types of congenital heart disease. I'm not going to talk about individual lesions, but we are going to talk about various groups, which I will show you now. Now, I'm not able to move further. Okay. We all know that, I'm sorry, I'm not going to go through this.
Dr. Dinesh, please help.
Just a minute.
Let's turn, sir.
I'm sorry about this. I'll just quickly. So what we do is we always follow a systematic approach, first of all, in the diagnosis of congenital heart disease. There are two types of diagnosis in this group of children. One is what is known as the physiological diagnosis, which I will mention later, where we divide them into various physiological groups. Is somebody who's moving the slides?
So control is with you, sir. I think so.
Yeah, but it is moving by itself.
Just see कि कोई
Okay.
बटन तो प्रेस नहीं रह गया.
Somebody is doing something here.
Sir, it is at all your end only. We don't have any control. So just see आपका लैपटॉप का बटन कहीं प्रेस तो नहीं रह गया. उसको just check करिए sir.
Oh, this is impossible. I don't know. Just a minute, please. ये क्या हो रहा है? अपने आप मूव कर रहा है स्लाइड्स.
अमित देखो कोई बटन प्रेस्ड रह गया है.
ये प्रेस कुछ रह गया होगा सर. एक सेकंड.
किसने
ये
प्रेस
कोई बटन.
सर वैसे कोई नहीं, मतलब आप जब आप एक कर तो उसमें हो गया होगा. एक सेकंड इसको बैक कर देता हूं.
कर क्या रहे हो तुम?
सर ये हैंग हो रहा है सर.
अमित if it is possible आप मेरे को स्लाइड भेज सकते हैं.
ये नहीं है. आगे से है.
सर आगे से हो जाएगा. एक बार वहां पे आने.
क्या हो जाएगा?
सर एक सेकंड.
1 मिनट या 40 मिनट हो गए. देर किया. वो सब बैठे हुए हैं वहां पे.
देखिए सर कौन सा स्लाइड है.
ये
सर भी अभी हैंग सही हो जाएगा उसका. एक 2 मिनट तक बोलिए.
अमित if it is possible आप मेरे को स्लाइड भेज दीजिए मेल पे so that I can shift the slides and sir can read.
सर ये स्लाइड बहुत हैवी है सर, ये नीज मेल पे नीज आ रही है। एक्चुअली जो सर की पीपीटी है ना काफी लेंदी है। यहाँ पे जैसे आधे के बाद जाती है ना ये।
आप एक काम करो ना, सर को फुल स्क्रीन पे मत लेके वैसे ही कर लो, कोई बात नहीं।
स्लाइड को फुल स्क्रीन पे ना लूं?
हाँ हाँ, अगर मान लो वो मूव कर रही है तो सर ऐसे वो कर लेंगे ना, नीचे कर लेंगे।
ठीक है सर, ठीक ठीक। ये शो हो रही है सर आप लोगों को?
हाँ अभी शो हो रहा है, कोई इशू नहीं।
ठीक ठीक।
अभी कहाँ मूव करूंगा मैं?
सर आई थिंक फुल स्क्रीन में इशू आ रहा है, तो सर आप डायरेक्ट वहां पे क्लिक करना जो भी स्लाइड्स।
Trying to come to my slides. I don't know what he is doing. I don't understand. He has no idea at all. ये क्या है?
नहीं नहीं अमित, यू आर मूविंग द स्लाइड, उसको आप छोड़ दो, कर्सर को छोड़ो आप।
सर
आप कर्सर छोड़ दो,
हाँ
यू आर
हाँ।
जस्ट मूविंग द स्लाइड अप।
नहीं मूव हो रहा है डॉक्टर साहब। आई एम सॉरी डॉक्टर मित्तल। I mean, this computer is
I
probably
can,
the first
I can.
computer which was manufactured. That's what he's got for me. Can I start now?
Yes sir, please.
I'm so sorry about this.
So we can understand, sir. No issues.
So, as I said, we follow always a systematic approach. We first have to make what is known as a physiological diagnosis, where we follow an algorithmic approach. Today, in the era of echocardiography, an exact anatomical diagnosis is very rarely needed. By this, I mean that there was a time when we were training, we had to make an exact anatomical diagnosis because that was the only, by clinical methods, because that was the only investigation available about 25, 30 years ago. But now, since we have the advantage of echocardiography, wherein we can easily get the exact diagnosis, such detailed clinical examination is gradually receding to the background. So, such sort of physiological diagnosis is possible in the majority of patients with auscultation, X-ray, ECG, etc. The exceptions are, of course, the newborn period or when a baby is sick and has to be ventilated. We are not going to specifically address that. Again, when we first started training, our teachers used to have, the pediatric cardiologists used to have a special room made for them, wherein they had a soundproof room, and so that all extraneous noises were eliminated, because a lot of these things used to depend upon what your auscultatory skill was. And we have to admit that their auscultatory skills were far, far ahead, and I don't think we can ever match them, because for them, that was the only modality, a combination of X ray, ECG, auscultation to make a diagnosis and then refer them for surgery. So this was the classical triad which we had to make a diagnosis: auscultation, ECG, X-ray. Now, of course, we have to add a tetrad to it, because no congenital heart disease can go for any treatment without echocardiography. What is the advantage of making this physiological classification? One, of course, for the diagnosis, which I was already talking to you about. Each physiological group has its own specific timing of treatment and planning of treatment, and each group will have its own follow up natural history. For example, if you see a patient of ASD and you treat them early in its natural history, like 4 or 5 years of age, which is recommended, there is no need to see them after 10 years of age. There is no follow up necessary. But if you see a tetralogy of fellow, it's going to be a lifelong follow up. So that is the advantage of knowing the natural history, and that only comes out of the physiological classification of these heart diseases. So this is a broad physiological classification. We divide them into the groups called decreased pulmonary blood flow, which includes patients of tetralogy of Fallot, transposition of great arteries, double outlet right ventricle. Then we have increased pulmonary blood flow, which includes the simplest of lesions like VSD, ASD. And then, of course, you come to more complicated cases like TGA VSD, double outlet right ventricle with VSD, truncus, single ventricle physiology with PS. So, the difference between the decreased pulmonary blood flow and the increased pulmonary blood flow is that the patients with increased pulmonary blood flow will not have pulmonary stenosis, and they will have unrestricted amount of pulmonary blood flow. Whereas the decreased pulmonary blood flow, you see that the groups are almost the same. They will have decreased pulmonary blood flow, and therefore they typically manifest with severe cyanosis. The third group is the obstructive lesion, wherein you can have venous obstruction, you can have right sided obstruction, left sided obstruction, and then there is this miscellaneous group called transposition of great arteries, which all of you are aware of. I'm sorry, there is a problem again here. So I'm going to give you a small brief about cyanosis. What is it that determines cyanosis in the patient who has a decreased pulmonary blood flow? And this was a chart which was made by my professor many, many years ago. And it clearly shows that the degree of cyanosis is dependent upon the pulmonary blood flow. It is the most important determinant of pulmonary of cyanosis. We talk about anemia, etc., but then the most important impact of a child who is going to have cyanosis is the degree of pulmonary blood flow. And you see from the left hand corner to the right side, you notice that this red column represents the degree of pulmonary blood flow. And you see, as the degree of pulmonary blood flow, that is the red column, keeps on decreasing, the cyanosis increases. In short, on a clinical basis, the greater the degree of pulmonary stenosis, which means that the greater the degree of curtailment of pulmonary blood flow, the more cyanosis the child would become. So, this is a basic principle which we always follow. We are clear that when a patient or the child who comes to you who is severely cyanotic will have a severe degree of pulmonary stenosis and severe degree of curtailment of pulmonary blood flow. Now, what are the components of decreased pulmonary blood flow? They have a large VSD, which is usually non-restrictive. Therefore, it will cause equal right ventricle and left ventricular pressure, and they will have pulmonary stenosis. So the two important things is they will have ventricular septal defect, and they will have pulmonary stenosis. Due to this, they will have a right to left shunt at the ventricular level and a cyanosis depending upon the degree of pulmonary stenosis, which I had talked to you about. So let me go quickly now. What are the classical features of decreased pulmonary blood flow? You see in all of these X-ray slides, whether it is a simple tetralogy of Fallot or complicated lesions like tricuspid atresia or double outlet, if you look at the lung shadows, you will immediately notice that there is a darkening of the lung fields, which typically indicates that there is a decreased pulmonary blood flow. Also, these patients do not have cardiomegaly unless it is complicated by other lesions. A typical tetralogy of Fallot will not show cardiomegaly, but it will show a decreased pulmonary blood flow. Also, you notice that the lung fields hardly show any pulmonary arteries. That is what is known as the stringy pulmonary arteries, because there is hardly any flow going into the pulmonary circulation. Of course, I'm not going to discuss the ECG today. What about increased pulmonary blood flow? How do you recognize them? You can easily recognize them by looking at the child, because they have failure to thrive, they have tachypnea, they have all the features of congestive heart failure. Of course, the X-ray will show cardiomegaly, and clinical examination will also show cardiomegaly, and you will always notice that it is a hyperactive precordium. The same way, if you look at a decreased pulmonary blood flow, you will see that the chest is absolutely quiet. Typically, they are able to gain weight. They are not tachypnic unless they are in what we call as cyanotic spells, and they will not have congestive heart failure unless it is complicated by some other problem. So this is how you recognize clinically a decreased pulmonary blood flow and an increased pulmonary blood flow. Okay, now let me go to an X-ray of an increased pulmonary blood flow. You immediately notice the difference between an increased pulmonary blood flow X-ray and a decreased. Here you see cardiomegaly. And if you look at the lung fields, you see a lot of blood vessels on the periphery of the lung fields, what is known as the plethora. So it immediately differentiates between a group with decreased pulmonary blood flow and an increased pulmonary blood flow. See, these are all at clinical levels as to how we recognize. In fact, as you get used to it, it is remarkable how you can immediately categorize them into these two categories by looking at the child, by carefully examining the child. Let's forget about the murmur and all, and you can easily make out these difference with the combination of clinical examination and ECG, X-ray. So now let's go on to our management strategy. I'm sorry, all these were not supposed to be present in the full screen, and it is quite embarrassing for me. So let's go to the management. First of all, we have to know what are the concerns of a decreased pulmonary blood flow. The most important thing is, of course, hypoxia, because of the very nature of the lesion. And when the hypoxia is severe, they go into spells. You all heard of spells. All of you in your practice must have seen a patient or a child with cyanotic spell. When they are left untreated, of course, they develop polycythemia, and then other consequences like brain abscess, infarct. Because of the polycythemia, they can have coagulopathies, platelet dysfunction, especially qualitative platelet dysfunction. Ventricular dysfunction and arrhythmia are a feature of late neglected congenital heart disease. You don't see ventricular dysfunction in a child with tetralogy of Fallot or a transposition. They all develop very late in the natural history. Arrhythmias also is very late in the natural history of untreated congenital heart diseases. We know that A hypoxic spell depends upon the degree of pulmonary stenosis. An extreme end of the spectrum is, of course, pulmonary atresia, where there is hardly any blood going into the lungs. It is all duct dependent, and the moment the duct closes, the baby is dead. Polycythemia is a complication of untreated hypoxia. Typically, you don't notice them in children or infants, but later, as the lesion keeps on getting untreated, they start developing polycythemia. The brain abscess is related to, of course, the right to left shunt, which occurs across the ventricular septal defect. Then it has been noticed very frequently when a neglected child or an adult comes to you with tetralogy of Fallot. It is a practice for us before we offer them surgery to do a CT, and you will be surprised the number of patients who have the so called hypoxic infarcts, which are actually asymptomatic. But if you look at them, sometimes it can be very scary. Ventricular dysfunction, of course, as I said, is a consequence of long standing untreated hypoxia. And later on, even treated patients who are neglected, who develop pulmonary regurgitation, etc., can have ventricular dysfunction. But typically, these are all features of grown up congenital heart disease rather than in the pediatric population. Arrhythmias, again, there are late features. You can have bradyarrhythmia, tachyarrhythmias, depending upon the type of lesions we deal with. And many of them are related to atrial surgery, the Fontan operation, or during surgery, they can have AV nodal injury, and of course, ventricular dysfunction. What about increased pulmonary blood flow? There, the concerns are completely different. Many of these children or babies or infants who are not operated in time would actually die of heart failure related to large flow. So, the most important consequence is actually heart failure. Then, of course, they develop pulmonary hypertension, progressing to pulmonary vascular obstructive disease and an Eisenmenger syndrome, which are typically occurring in large or sometimes in moderate defects, but typically they occur in large defects. Then, like in decreased pulmonary blood flow, they can develop ventricular dysfunction late in the natural history and, of course, cardiac arrhythmia. It is said that sudden cardiac death is one of the commonest causes of death in untreated congenital heart disease associated with an Eisenmenger syndrome. So they actually die suddenly because of the effect of the severe pulmonary hypertension, which has reached an Eisenmenger situation. Heart failure typically occurs in neonates and infants with VSD, PDA, AP windows. In atrial septal defect, heart failure typically occurs in the fourth decade onwards. You don't see heart failure because of atrial septal defect in neonates and infants or even children. Pulmonary hypertension in all large VSDs, PDAs, AP windows. This is one of the most important slide which you should notice as a pediatrician, that the pulmonary vascular obstructive disease actually starts as early as 3 to 6 months. This is a thing which all of you should note. Please do not wait to treat a large VSD, PDA, AP window till 2 or 3 years of age, because it is not uncommon for us to tell them, look, it's too late because the pulmonary hypertension has now progressed to pulmonary vascular disease and there is nothing that we can do about it. And that is something which has come out of our understanding of pulmonary hypertension, what it does to the pulmonary circulation, and how quickly this whole thing can become irreversible. Ventricular dysfunction and increased pulmonary blood flow, as I said, usually occurs in long standing untreated large shunts, which has not progressed to Eisenmenger but has now started creating trouble in the form of ventricular dysfunction. It is most common in atrial septal defect, simply related to the long survival of these group of patients, but occasionally we also notice them in untreated PDA VSD with a large shunt. But typically, if you talk about ventricular dysfunction in these groups of patients, it is usually in the third or fourth decade, something which you will never see as a pediatrician. And the most common lesion is, of course, ASD. Patients with VSD, PDA, etc., would have been long before dead before they develop these complications. Arrhythmia, again, in increased pulmonary blood flow, usually occurs in adults, and typically they are in patients of atrial septal defect because they are able to survive long. And as I recently told you, that VSD, PDA, Eisenmenger syndrome, sudden cardiac death is not very uncommon, and they are related to ventricular arrhythmias. They suddenly develop ventricular tachycardia, ventricular fibrillation. Fortunately, again, you don't see these group of patients because they usually reach the adult life. What about left-sided lesions? What are the problems related to this? That is aortic stenosis, whether it is valvular, subvalvular, supravalvular, or coarctation of aorta. And the right-sided lesion is, of course, pulmonary stenosis. What happens to them? They develop ventricular hypertrophy and fibrosis if you delay their treatment. Aortic stenosis will develop LVH and fibrosis of the left ventricle. Pulmonary stenosis will develop right ventricular hypertrophy and fibrosis. This progresses onto ventricular dysfunction and failure. This ventricular dysfunction and failure can occur very early in the natural history. It can occur in infants and children, especially if it is untreated. And then, of course, these group of patients, especially the left-sided lesions, are prone to sudden cardiac death, especially when they are exercising if you don't treat them in its severe phase. Now, before going on to the management, I'm going to give you 2 or 3 definitions, which is very important for you to remember, because a lot of these management strategies come with the definition of various terminologies. You must have, of course, heard of single ventricle physiology or single ventricle anatomy. What is the meaning of this? A single ventricle basically means that there is only one good sized ventricle and the other anatomically small, which can never be used in clinical practice for the patient. Sometimes you can have two good sized ventricles, but one of them cannot be used because of various reasons. But typically, a single ventricle has only one ventricle. The other one can be actually seen by various imaging modalities, but unfortunately, it's so small that it is of no use. So, this is some of the pictures of a single ventricle physiology. In the extreme left, you see that there is hardly any ventricular septum. In the middle picture, you see that the tricuspid valve has not developed, and therefore the right ventricle is very small. And in the third one, the mitral valve has not developed. The left ventricle is very small, so it is a single right ventricle. This is a single left ventricle, and this is a common ventricle. So these are the 3 types of single ventricle. Then, of course, we manage them in a different way. I'll come back to this later again about how we manage them. I'll show you these pictures later. There are 2 types of surgery, Glenn and Fontaine, which I will talk to you about. So, why is this important? There is this so-called concept of univentricular and biventricular repairs. The use of right ventricle as a pump to the lungs is preferable in the long term, which means that we would always like to do surgery which has two pumping chambers, the right ventricle pumping to the lungs, the left ventricle pumping to the body. Because if you can achieve such sort of repair, then of course that is the best solution. In a single ventricle repair, which I will talk to you later, it is not possible to do that. So, whatever you do, whatever management strategies you use, their life can never be the same as in a patient who has a two ventricle pump. So, this is a very important concept in congenital heart disease. So, our attempt always, we might not be successful, is to do what is known as a biventricular repair instead of a univentricular repair. The second important thing which you have to remember is what is known as a conduit. Sometimes to bypass the lungs, because the lungs are not connected to the right ventricle, you have to use conduits in order to bypass. I'll quickly show you this image and then move on backwards. You see this tube here, which is used to connect the right ventricle to the pulmonary artery. This is what is a conduit, because in the original anatomy, there was no connection between the right ventricle and the pulmonary valve. So they had to put a conduit in order to provide this circulation. Of course, it looks very nice, but then there are definite problems with conduit because it has a definite time span of utility. It undergoes degeneration, calcification, obstruction, outgrowth, and many times repeated surgeries are necessary for conduit. It is said that typically a conduit would last for about 8 to 10 years and then we have to change it. There are a lot of innovations going on in the field of surgery for these group of patients where they would like to do a surgery without using a conduit. But I'm not going into that the detail. And we would also like to have a child to have a surgical repair without the use of a conduit, if it is possible, because they all are going to degenerate over a period of time. The third discussion, which I had partly alluded to, is the concept of pulmonary hypertension and pulmonary vascular obstructive disease in congenital heart disease. It is extremely crucial in our management strategy. Pulmonary arterial hypertension is present in all patients who have large defects like VSD, PDA, AP window. There is so-called early stages, which is known as the hyperkinetic PAH, where increased pulmonary blood flow and decreased pulmonary vascular resistance is still present. These patients, these children are still operable, but if it is untreated, they move on to what is known as the obstructive phase, which is what we were discussing about pulmonary vascular obstructive disease. They have now a decreased flow and increased pulmonary vascular resistance. So these are patients of pulmonary hypertension, and it is very, very important to recognize them early because they very quickly start developing microscopic irreversible changes when you do lung biopsies. In the group of patients who are cyanotic, for example, transposition with VSD, truncus with VSD, these changes on the microscope on lung biopsy has been seen as early as 3 months of age. Of course, the exception to all this is patients with atrial septal defect, where pulmonary arterial hypertension is very rare. Less than 10% of them develop uh, pulmonary hypertension. It is not uncommon to see a 40, 50, 60-year-old patient who has a huge ASD, very large ASD, but if you measure his pulmonary artery pressure, it is normal. So it behaves completely different from what is known as the post-tricuspid shunt like VSD, PDA, AP window, whether the child falls under the cyanotic group or in the acyanotic group. So now let's go on to our management protocol. Let's talk about the increased pulmonary blood flow, which means large VSD, AP window, PDA. Early surgical correction before 6 months is absolutely essential in these group of patients, and that too if they are thriving, that is, they are gaining weight. If they are not able to gain weight, then we have to operate them early in the natural history. For example, today I saw a patient of truncus arteriosus. The child is 1 or 2 months and has actually started losing weight. If you try to wait or sit on these group of patients, they are not going to survive. They are going to die of congestive heart failure or they will die of pulmonary vascular disease. So now the skills of the cardiac surgeon who does congenital heart surgery is so developed that they are easily able to operate on these group of patients and give them a meaningful life. Then we have what is known as the moderate size ventricular septal defect. In these group of patients, we can actually wait till 2 years of age, but not at the expense of failing to thrive. Why do we wait till 2 years of age? Because there is some chance that these moderate defects can actually close over a period of time. But large VSTs, PDAs, AP windows are not going to close. So we have to do it. And pulmonary vascular obstructive disease in moderate ventricular septal defect is not very common. It can occur, so you have to keep them under close observation. But typically, we are able to do it till about 2 years of age in the hope that some of them can become small. So, what happens? I don't know, something gone wrong. This is one of the worst presentations I have ever given. I'm so sorry about this. I don't know. How the I'm again sorry. I hope you have all not left here. Hello.
We are all
Yes, sir.
there,
We
sir.
are here, sir.
We
Okay.
can understand there are
Sorry
difficulties,
again.
sir, and it's nothing in nobody's hands, sir.
The third category is the no, but these guys are expert in goofing up, so don't say that. This is not the first time I've had a problem with them. So, anyway, we move on to the small ventricular septal defect. Typically, they don't have any pulmonary hypertension. So, by definition, a small ventricular septal defect are patients who do not have pulmonary hypertension. Their ECG is normal, their X ray is normal. So we would do medical follow up till at least about 10 years of age, in the hope that approximately 50 to 75% of them would automatically close. There is a high incidence of spontaneous closures of some of these ventricular septal defects, especially the muscular ventricular septal defect. It is said that 80% of them, if they are small, are going to close. But there is a group of small ventricular septal defect who we would still advise closure. They are, some of the VSDs are associated with aortic valve prolapse with aortic regurgitation. We have to immediately operate on them. The concerns now are not with the VSD but with the damage to the aortic valve. Again, all these are so easily picked up by echocardiography that you don't need any further. Your auscultatory skills are not going to work because we have to pick them up very early in the natural history. And that can be easily done by echocardiography. The second complication of any small ventricular septal defect is infective endocarditis. It is so rare that we hardly see them. We might see one case in a year in our setup. So, once you have infective endocarditis, then typically we would like to advise them surgery. There is still controversy going on whether you should have one episode or two episodes. I don't think it is fair on the patient to tell them that, look, let's wait for another episode of infective endocarditis. We have to go ahead and close it. Having said that, it is an extremely rare thing to have infective endocarditis. The current recommendation actually has removed infective endocarditis prophylaxis for any dental or any other procedures in patients of small VSD because it is so rare. But they do emphasize, and that is where the pediatrician's role is so crucial, to practice good dental hygiene, even though we are not operating on the ventricular septal defect, but they should practice good dental hygiene because most of the infection actually spreads from poor dental hygiene. Then, of course, there is this rare group, I'm not going to talk about it, from left ventricle to RA shunt. You must have heard in your MBBS or MD time what is known as the Garbode defect. We have to operate on them, even though hemodynamically these are all small lesions. Is there any scope for non surgical closure of ventricular septal defect? Because that is a question which frequently parents come and ask us. Remember that the ones which have large VST, PDA, AP window, or let's talk about VST, there is no scope for non-surgical treatment. We make it very clear to them that when an infant or a small child comes to us with large VST, with failure to thrive, heart failure, PH, there is only one treatment, and that is surgical closure of VST. But percutaneous closures with devices is still can be practiced. Typically, they have to be moderate in size. They have to be, babies have to be, children have to be at least 8 to 10 kilos, which, if you actually look back retrospectively, a large VST will never attain this weight. They will be dead or they will have severe PAH. For muscular VST, it is now a well established technique. But for perimembranous VSD, which is very close to the aortic valve, perimembranous defect is defined as a VSD which is close to the aortic valve. It is a very controversial topic. I'm not going into it, but these children can develop heart block and damage to the aortic valve because both the conduction tissue as well as the aortic valve are very close to the defect. So we have to be very careful. So this is the type of device which we now have with us. And you can see that this VST, which is present in the muscular septum, has been closed without any surgical interference, and the babies are discharged or children are discharged the next day of the procedure. But there have to be conditions which have to be fulfilled, which I have discussed with you. I'm not going to talk about perventricular. You can see that the child has had device which is placed in the ventricular septum at the time of surgery, but the scope of this is now very limited, so I'm not going into the details. PDA can now, it is actually the treatment of choice, except in the very, very small babies. Here, the moderate size and the small PDA need not have any surgical treatment at all. They are all closed by device therapy, and nobody talks about surgery for moderate and small PDAs. It is surgery is typically practiced, for example, in a premature infant with a large PDA, or a very small child less than 3 months or less than 6 months who has not achieved this particular weight. Otherwise, we will all close them by devices. It is a well established technique, more than 15 years of follow up. There is a 100% occlusion rate at 3 months, but then we have to carefully select these patients because there is a potential for complication by devices also. So one has to be very careful. You cannot say that all PDAs I will close by device, so it has to be carefully selected. But having said that, once the child reaches 1 year of age and it is a moderate or a small PDA, then there is no question of any surgical treatment for these group of patients. Here is a device which looks slightly different from that of a VSD device. And this is an example of a child with a PDA. You can see the connection between the aorta on the right side and the pulmonary artery on the left side of the screen. And this is the PDA, and now it has been sealed by a device, and the patients are discharged the next day of the procedure. What about ASD? The current recommendation is to close atrial septal defect anytime after 2 years of age. It is very rare to advise closure of an atrial septal defect before 1 year of age. Very rarely, these group of patients have PAH, severe failure to thrive, persistent congestive heart failure, but remember that it is very rare. But any child who has a large atrial septal defect, you can wait, keep on documenting the pulmonary artery pressures, and if it is normal, which in 90% of cases it will be normal, then you can wait up till 2 years of age and then advise closure. What about non surgical treatment of ASD? Yes, this is very well practiced now for the reason that we can actually wait in these group of patients till they are of 2 years, 4 years, 5 years. And if they have adequate margins all around, if they are more than 12 kilos, which most of the ASDs would reach because they are usually asymptomatic, it is a well established technique and we have long term follow up. If you look at the device, this is how it looks like. There are two discs, one on the left atrial side, the other on the right atrial side. And this middle portion actually sits on the defect. And this is a fluoroscopic image where the device has been deployed. We usually do it under transesophageal echo guidance and then completely seal it off. Excellent results. We then move on to uh, what is known as the cyanotic group, out of which the first one of them is the total anomalous pulmonary venous connection. Remember that they are always sick from the newborn period. There is a very rare subgroup which will present later in life. Surgery has to be done at the time of diagnosis. No question of waiting on TAPVC. And if you remember the group of patients with obstructed TAPVC who present immediately after birth, they have to have surgery immediately after birth. No question of waiting because they will not survive. We now go on to some of these complicated issues of cyanotic congenital heart disease. You remember I classified them into decreased pulmonary blood flow and increased pulmonary blood flow. Now, these group of patients who can have a biventricular repair, I discussed about it before, I told you that biventricular repair is always preferred over univentricular repair if the anatomy is suitable. You can classify them into two groups. One who do not require a conduit. The typical example is tetralogy of Fallot, double outlet right ventricle with pulmonary stenosis, etc. And the second group who would require a conduit. I discussed about this before this about conduits. So the group of patients who require conduits are TGA, VSTPS, double outlet right ventricle with PS, whereas people who don't require conduit, the typical example is tetralogy of Fallot. How do we manage them? Oh, sorry, before that, there is a decreased pulmonary blood flow who require univentricular repair. That means the other ventricle is hopeless. There are patients of tricuspid atresia with PS, mitral atresia with PS, double inlet left ventricle with PS. So they are the same group of patients who have pulmonary stenosis like tetralogy, but they have only one functional ventricle. So we then move on to the, I'm again into trouble. I don't know what happens to this. फिर से हो गया. ये हटाओ.
Just press escape key. Escape key कर दो तो हो जाएगा.
Thank you. We have a wonderful person guiding me. So these are the group of patients with univentricular repair. They are all have pulmonary stenosis, but they have only one ventricle present. So how do we manage them? Biventricular repair who do not require. Okay, before I go to that, I'm sorry. I'm a bit disoriented because of this interruption. We then go on to the increased pulmonary blood flow, who are typically cyanotic. Again, we classify them into ones who do not require a conduit. They are patients of TGA, VST, again without pulmonary stenosis. Then double outlet with TGA without pulmonary stenosis. And there is only one patient in this group who will require a conduit, and that is the truncus arteriosus. And the fourth group is increased pulmonary blood flow who require univentricular repair. So, to briefly summarize this, you have two groups, increased flow, decreased flow. Within the decreased flow, you have two groups, one who can be managed with two ventricles and one can be managed only with one ventricle. And also in the increased pulmonary blood flow, who can have two ventricle repair and you can have one ventricle repair. The lesions are similar. With increased pulmonary blood flow, you don't have any pulmonary stenosis. With decreased pulmonary blood flow, you have pulmonary stenosis. So now let's see what happens. Decreased pulmonary blood flow group where biventricle repair is possible without the use of a conduit. Again, to recall, the typical example is tetralogy of Fallot. Here, the treatment depends upon the degree of cyanosis. If they are not very cyanotic, we would do an early total repair at 6 months of age. So today, tetralogy of Fallot is corrected by 6 months of age. But of course, you know that there are certain tetralogies who come to you with severe cyanosis, spells in the neonatal period. These group of patients will require a neonatal shunt. Then the ones which require a conduit, because they are very small and we require to put a larger conduit if they are asymptomatic or they do not have too much of cyanosis, then we would actually wait till about 3 to 4 years of age and then put a conduit. So the ones which require a conduit with decreased flow, we will wait till 3 to 4 years if it is possible. But if they are very, very sick, very blue, then we might again do a shunt and then wait for 3 to 4 years because we require a conduit. So, how you have to remember is that if somebody requires a conduit in decreased pulmonary blood flow, then we have a tendency to wait, but not for the typical tetralogy. By 6 months of age, we have already corrected it. I'm again getting into trouble. Okay, this time I could manage. Thanks for the suggestion. Now I can use the escape this thing. Now, in the group of these patients where biventricular repair is not possible, that is tricuspid atresia, mitral atresia, single ventricle, we would again depends on the degree of hypoxia. If it is severely hypoxic, we will do a neonatal shunt. Then we do what is known as a Glenn shunt, and then we do the Fontaine operation. Let me take you to that original picture of what is a Glenn shunt and what is a Fontaine operation. A Glenn shunt is when we disconnect the superior vena cava, and there. This is the superior vena cava. We have disconnected it from the right atrium and connected it to the pulmonary artery. A Fontaine operation, which is the next stage to that, is we take the inferior vena cava, take a conduit, and connect it to the pulmonary artery. So, what do we achieve at the end of these operations? Is that we have separated the deoxygenated blood from the oxygenated blood because there is only one ventricle which is functioning. This type of surgery is called the Fontaine operation. So this is the Fontaine operation, typically done after 2 years. So the Glenn operation, which is done between 6 months to 12 months, will give relief to the cyanosis to a certain degree. But after the Fontaine operation, they will completely become acyanotic. But there are a lot of issues with Fontaine operation for any single ventricle physiology. I'm not going to discuss that. Remember that these patients do not live a normal life. They are on continuous follow up with the cardiologist. They require some medications or the other. They are prone to some complications or the other during their lifetime. Increased pulmonary blood flow, where two ventricle repairs are possible. And I told you there are only two conditions, TGA VST and truncus. Now, TGA VST does not require a conduit. They undergo the arterial switch operation, whereas a truncus will require a conduit. However, these conduits cannot wait till 4 to 5 years, unlike the patients who have decreased pulmonary blood flow. So you have to put a conduit within 1 to 3 months of age, irrespective of use of conduits. And therefore, the implications are within 1 year, these patients will require a conduit change. You can't do anything because imagine at 3 months, the type or the size of conduit that you can place will irreversibly require, without any fail, would require a replacement of the conduit by 3 months. However, if you put a conduit at 4 to 5 years of age, they would easily last for about 10 years of age. But the nature of the illness is such that if you wait for a truncus to put a conduit at 4 to 5 months of age, they are not going to survive or they will develop severe pulmonary vascular disease. What do you do when two ventricle repair is not possible with increased pulmonary blood flow? If you look at the algorithm, it is the same as that of decreased pulmonary blood flow, except that instead of a BT shunt, we have to perform a banding of the pulmonary artery in order to protect the child from heart failure and pulmonary hypertension. So this is mandatory. Whereas if you look at this slide of a neonatal shunt, it is not mandatory. It depends upon the degree of hypoxia. But here you cannot escape. You have to do a banding before 3 months. Then you move on to the same thing, Glenn operation, and then the Fontaine operation, which I had shown you pictures. So this is how we manage these group of patients. What about obstructive lesion? If the obstruction is at the valvular level, for example, valvular pulmonary stenosis, there is only one treatment now which is recommended, and that is balloon dilatation. No other treatment is preferred in these group of patients. Excellent results. The mortality, whatever it occurs, is only in a sick newborn who are duct dependent. Otherwise, the results are excellent. So, just a pictorial representation. This is the pulmonary narrow valve here. So we take a catheter with a balloon from the femoral vein, cross the pulmonary artery, and then inflate the balloon to open it up. And that is now become a simplified procedure. The only morbidity that we see is in a newborn period who has critical pulmonary stenosis who cannot wait. What about, however, if the obstruction is below the valve or above the valve, these two group of patients will always require surgery, what is known as the subvalvular obstruction and supravalvular obstruction. Supravalvular obstruction is typically what you see in Noonan syndrome or Williams syndrome, Alagille syndrome. All these patients cannot be treated with balloon dilatation. They will always require surgery. Valvular aortic stenosis, again, the best option today is do balloon dilatation. Previously, they all used to have surgical valvotomy, but even now the surgeons prefer that they undergo balloon dilatation. Excellent results. They are life saving in newborns who come to us sometimes in a shock stage. However, restenosis can occur, but at least it's a life saving procedure. Again, this time we go through the femoral artery, we cross the aortic valve here, then take the balloon and blow it up, and it opens up the uh, dramatic results. If there is left ventricular dysfunction, it immediately regresses by the time the patient gets discharged. Again, if the obstruction occurs in the supravalvular or subvalvular region, unfortunately, only option is surgery. You cannot do balloon dilatation below the valve, above the valve, whether it is in the pulmonary or the aortic position. What about transposition of great arteries? I showed you that it is a miscellaneous lesion. You all know that neonatal arterial switch is the treatment of choice today. Here is where the responsibility lies on the pediatrician in order not to miss the diagnosis. This should be diagnosed before the child leaves the nursery or ICU after birth. There is no question. Ideally speaking, today, it should be diagnosed during fetal life. If that is so, then everything can be planned and treatment can be offered. Today, the risk of neonatal arterial switch is less than 1%. That is the level of expertise our surgeons have reached, and they can lead a normal life. There is another option which is known as the Senning operation, which occurs in children or babies who have not been diagnosed as TGA and come to you at 3 months or 4 months of age. Here, arterial switch is not possible. You have to choose an alternate operation, and here the results are not very good on a long term basis. Short term, it is very good. Cyanosis will disappear, the baby will get discharged, but there are issues in the long term which you don't see in the arterial switch. So that is where we emphasize that please do not miss a TGA before the baby goes home. Either the child would be dead by as soon as the duct closes, or it will have the unfortunate option of going on to the Senning operation. So this is what is the arterial switch. Here you see the left hand picture. The aorta arises from the right ventricle, the pulmonary artery arises from the left ventricle, and here the surgeon has cut these two vessels and switched it so that now the right ventricle pumps into the pulmonary artery, the left ventricle pumps into the aorta, and here which is one of the most delicate operation. Of course, he has to also translocate the coronary arteries. Imagine a 2-month-old newborn, the coronary arteries you will hardly be able to see, but that's the level of expertise our surgical colleagues have reached, with a mortality which is reached now 1%. I'm just trying to compare our results with that of the Society of Cardiothoracic Surgeons, European Association of Cardiothoracic Surgeons. It is not strictly comparable, but you can see in all the group of patients, the total mortality at 30 days has now reached 2.94%. The major mortality is in the newborn period, but that too only for palliative surgery, not for corrective surgery, like PA banding, neonatal shunt. And then after 1 year, the overall mortality is now become less than 1%. So this is what we are able to achieve. It's a team effort. Cardiologist, surgeon, anesthetist, perfusionist, intensivist, pediatrician, nurses, and paraclinical staff. And we have always noticed entry of any new staff, especially the nursing staff, at any level affects the results of the surgical or interventional skill. So this is just a flow diagram to show that we have to work together to achieve this. So, in summary, majority of congenital heart disease are correctable with almost normal lifespan. Why do I say that? Because majority of congenital heart disease are constituted by ASD, VSD, PDA. Some of them are palliative. For example, the Fontaine operation is a palliative operation with significant improve in quality of life. If you see some of these Fontaines who come to us, you cannot guess that they have undergone these three-stage surgeries. However, there are some complex congenital heart disease which I have to admit is incorrectable. For example, hypoplastic left heart syndromes, and there are other complex heterotaxy syndromes. Early referral and correct timing is the key to good results. We have problems in developing countries. One of the most important thing is undiagnosed heart disease in the newborn. And I spoke to you about two lesions which are so correct, eminently correctable. One is obstructed TAPVC and the other is transposition. If we can diagnose them, we can give normal life. Then, of course, we have this problem of late referrals where they come to you in pulmonary vascular obstructive disease, polycythemia, they are malnourished. And of course, we have to talk about financial issues. But today, there are so many philanthropic organizations, etc., which provide treatment at very low cost, provided, of course, somebody is there to guide them. This is what we used to see when we started the program about 25 years ago. Neglected pediatric congenital heart disease, severely polycythemic, severe failure to thrive, cachexia. But we now see them less often. I'm sure the government hospitals would be seeing them. I cannot deny that. But we have now, because of this awareness, ability to convey help from the pediatric group, especially with early referral, we now see children like this, newborn babies who have been operated so early in the natural history and with excellent results. Thank you very much. I think I have finished my talk. I'm extremely sorry for this interruptions in this talk. And
No, sir. Thank you so much, sir. It was undoubtedly very nice presentation. So वो जो presentation में fault था sir, उसमें तो कुछ कर नहीं सकते. That was some technical problem, sir.
no, it occurs every time with me. Don't try to support them. Useless people. Anyway, thank you so much.
Yes, sir. Dr. Dinesh. Any question?
Thank you very much, sir. I think whatever the technical glitches, you have made it so interesting. So I think all the audience were there till last, and it was really nice and interesting. I think if there is some question and answers, we can
Yeah,
take.
it's a difficult topic. I understand. I can share with you anytime you wish keep on re-emphasizing because of the complexity of the problem. And that is why I said I'm not going to discuss individual lesions, but rather discuss as a group. And of course, we can communicate anytime whenever you feel like it.
So I just wanted to ask about muscular VSD. You
Yes.
said in this all muscular VSD, usually 80% of muscular VSDs will close by time.
Yes.
So what time till what time, what age we can wait?
Again, it depends on the size of the VSD. If a large muscular VSD, which is causing pulmonary hypertension, failure to thrive, heart failure, please do not wait. You should operate them before 6 months. But if it is a moderate size or a small VSD, that has a lot of potential to close. Even large VSDs has the potential to close as compared to other VSDs, but unfortunately, if you wait, they are going to die of heart failure and pulmonary hypertension, etc. So the 80% of VSDs, muscular VSDs which close, basically refer to the small and moderate defects.
Oh, okay, sir. So what do you mean by small, like
Okay,
dimensions
the
wise, sir?
large, small, and moderate defects we always define by echocardiography. A
Right.
large defect will have pulmonary hypertension. A moderate defect is not going to have pulmonary hypertension, but the chambers will be dilated. Whereas a small defect will have no pulmonary hypertension, no cardiac dilatation, normal ECG, normal X ray. So, this is a combination by clinical examination, X ray, ECG. But today, of course, echo is one of the best modalities.
Yes, sir. And sir, what about ASDs? Small ASD, can we wait? And if we can
Oh,
wait,
yes.
till what
ASDs can always wait. It is said that there is some data to show that if your ASD at the time of birth is less than 6 millimeter, almost all of them will close. If they are more than 8 millimeters, they are unlikely to close, but there is no hurry. As I said, you can easily wait till 2 years, give them chance, a small chance that it might close, and but after 2 years, you can take a decision to close it. Some people say you can even wait till 4 years.
Yes, sir. Thank you, sir. Over to you, Dr. Dinesh.
Okay, thank you very much, sir. I think there are no more questions, and we have really benefited by your talks. We always get benefited. Even the last time, also, the hypertension talk was so popular, and even after this talk, a lot of people saw it on the YouTube also, and even this talk will be available on the YouTube also. So, thank you very much, sir.
Thank you. I'm again sorry, apologize for the
No, no, not
confusion.
at all, sir. Not
Yes,
at all. Please, sir. No, sir.
Thank you.
thank you, sir.
Thank you very much, sir. Thank
Bye.
you.